Just a sec, guys. Alright, let's continue talking about Lynch syndrome. So explain to me.
All right,
Explain
let's
to
clarify.
me MSH2 and MLH1 and all of that.
All right, let's break down MSH2 and MLH1 in the context of Lynch syndrome, keeping it clear and simple. MSH2 and MLH1 are mismatch repair genes that act like spell checkers for DNA, fixing errors during cell division to prevent mutations. In Lynch syndrome, inherited mutations in MSH2 on chromosome 2 or MLH1 on chromosome 3 disable this repair system, causing DNA errors to pile up, especially in repetitive DNA sequences called microsatellites, leading to microsatellite instability. This speeds up the adenoma to cancer sequence, raising the risk of colorectal, endometrium, and other cancers, with MSH2 mutations often linked to a broader cancer spectrum and MLH1 to a slightly higher colorectal focus. Want to dive deeper into how these mutations are tested or their specific cancer risks?
Yeah. And tell me how Lynch syndrome is assessed using the Amsterdam criteria.
Lynch syndrome is assessed using the Amsterdam criteria to identify families likely to have hereditary non-polyposis colorectal cancer, HNPCC, based on clinical history, not genetic testing alone. The Amsterdam 2 criteria require at least 3 relatives with Lynch-associated cancers, e.g., colorectal, endometrium, small bowel, ureter, or renal pelvis, with one being a first-degree relative of the other 2. Cancers occurring in 2 successive generations, at least one diagnosed before age 50, and familial adenomatous polyposis ruled out. These strict criteria help pinpoint families for further testing, like microsatellite instability analysis or MSH2 and MLH1 gene sequencing, but they miss some Lynch cases due to small family sizes or atypical cancers. If criteria are met, genetic counseling and testing confirm mutations in mismatch repair genes like MSH2 or MLH1. Want to explore these tests work or the Bethesda guidelines for broader screening?
Explain to me screening more and PR bleeding. Please.
All right, let's dive into colorectal cancer screening and PR per rectal bleeding, keeping it simple and clear with 2 sentences per response, as you like. Colorectal cancer screening. Screening for colorectal cancer aims to catch it early or prevent it by finding precancerous polyps or early cancers, especially in average risk people over 50 or those with risk factors like Lynch syndrome or inflammatory bowel disease. Common methods include colonoscopy, which visualizes the entire colon to remove polyps, fecal occult blood tests, FOBT, or fecal immunochemical tests, FIT, which detect hidden blood in stool, and sigmoidoscopy, which checks the lower colon, with screening intervals varying by risk, e.g., every 10 years for colonoscopy in average risk individuals. For high-risk groups, like those with Lynch syndrome, screening starts earlier, often at age 20-25, and is more frequent, like annual or biennial colonoscopies, due to faster cancer progression from mismatch repair gene mutations. Genetic testing for MSH2, MLH1 mutations, guided by Amsterdam criteria, helps tailor screening, while CT colonography or stool DNA tests are less invasive options, but less sensitive than colonoscopy. PR bleeding. PR bleeding, or blood from the rectum, is a key symptom prompting colorectal cancer screening, as it can signal polyps, cancer, or other issues like hemorrhoids or ulcerative colitis, though it's not always cancer-related. In colorectal cancer, bleeding often comes from ulcerated tumors or friable polyps in the colon rectum, appearing as bright red blood, distal tumors, or darker, mixed in blood, proximal tumors, and requires urgent evaluation via colonoscopy or imaging. Bright red PR bleeding suggests a left-sided colon or rectal source, like a cancerous mass or polyp, while darker blood points to right-sided colon issues. But any persistent or heavy bleeding, especially with weight loss or anemia, needs immediate investigation. Screening triggered by PR bleeding can catch cancers early, with colonoscopy being the gold standard to pinpoint the cause and guide treatment, like polyp removal or biopsy. Want me to zoom in on specific screening tests, like how FIT works, or dig deeper into how PR bleeding is evaluated in clinic?
Let's talk about the staging of bowel cancer and explain to me T tumor and lymph distant metastasis.
All right, let's dive into the staging of bowel cancer, or colorectal cancer, focusing on the TNM system, which stands for tumor, T, nodes, N, and metastasis, M, used to describe how advanced the cancer is. I'll keep it clear, simple, and stick to 2 sentences per response, as you prefer. Tumor, T. The T category describes how deeply the primary tumor has invaded the colon or rectum's wall, starting from T0, no tumor, to T4, tumor penetrates through the wall or into nearby organs. For example, T1 means the tumor invades the submucosa, T2 reaches the muscularis propria, T3 goes beyond into the subserosa or fat, and T4A-B breaches the surface or adjacent structures like the bladder. Nodes, N. The N category indicates whether cancer has spread to nearby lymph nodes, with N0 meaning no lymph node involvement, N1 showing 3 nodes affected, N1A-B or tumor deposits in nearby tissue, N1C, and N2 indicating 4 or more nodes involved, N2A-B. Lymph node spread is a key sign of progression as cancer cells travel through lymphatic channels, impacting prognosis. Metastasis, M. The M category shows if cancer has spread to distant organs, like the liver or lungs, with M0 meaning no distant metastasis, and M1 indicating distant spread, M1A for one site, M1B for multiple sites. Distant metastasis marks advanced disease, often stage 5, requiring systemic treatments like chemotherapy rather than just surgery. Staging overview. The TNM categories combine into stages 0, 4. Stage 0 is carcinoma in situ, TS, N0, M0. Stage 1 is early invasion, T1, T2, N0, M0. Stage 2 is deeper invasion without nodes, T3, T4, N0, M0. Stage 3 involves lymph nodes, NET, N1, N2, M0. And stage 4 has distant metastasis, NET, NEN, M1. Staging guides treatment. Early stages may need only surgery, while later stages often require chemo, radiation, or targeted therapies. Want me to break down a specific stage, like what stage 3 treatment looks like, or dive into how TNM is assessed, like via imaging or pathology?
Okay, let's talk about T1, invasion of the submucosa.
T1 in colorectal cancer staging means the tumor has invaded the submucosa, the layer of connective tissue just below the colon or rectum's inner lining, mucosa, but hasn't reached the deeper muscularis propria. This early stage invasion, often found in polyps or small tumors, is usually treated with surgical resection, like polypectomy or local excision, and has a good prognosis if lymph nodes and distant sites remain clear. N0, M0. Want to dive into how T1 tumors are detected or what makes them progress to T2?
Yes, please. Can you do it in a nice storytelling kind of way?
All right. Picture this. Deep in the winding tunnels of your colon, a tiny rebel cell decides to break the rules. This troublemaker, part of a small polyp, starts to grow and sneak past the mucosa, the colon's inner velvet curtain, slipping into the submucosa, a soft, connective tissue layer just below. This is T1 colorectal cancer, the earliest stage of invasion, where the rogue cells are like sneaky adventurers who've crossed the first border but haven't stormed the castle walls yet. The muscularis propria is still out of reach. These T1 tumors are often caught by a vigilant guard, called colonoscopy, where a doctor, wielding a tiny camera, spots the polyp's suspicious bulge during a routine screening, perhaps triggered by a hint of blood in the stool, or a family history like Lynch syndrome. Sometimes, imaging like a CT scan backs up the find, but it's the biopsy snipping a bit of that polyp and peering at it under a microscope that confirms the cell's naughty behavior, showing dysplastic, crowded nuclei pushing into the submucosa. What nudges T1 to become T2? Well, imagine those rebel cells gathering more mutations, like picking up rogue allies, maybe a KRAS mutation turbocharging their growth, or a TP53 glitch disabling their brakes. These genetic plot twists let the tumor burrow deeper, past the submucosa, into the thick muscle layer, turning T1 into T2.
So we start from the inner layers, go to the outer, and then go to the other organs, or what?
Yeah, you're spot on about the progression. In colorectal cancer, like our T1 story, the tumor starts in the inner layer of the colon or rectum, the mucosa, that thin, slimy lining where cells first go rogue. From there, it creeps outward through the layers of the bowel wall, and if it gets bold, it can spread to other organs. Let's keep the storytelling vibe and break it down simply, sticking to 2 sentences per response. For a T1 tumor, those rebel cells have pushed from the mucosa into the submucosa, the soft, connective tissue layer just below, but they're still contained within the bowel's inner workings. It's like they've snuck into the basement, but haven't broken through the house's main walls yet. If the tumor keeps growing, it becomes T2 by burrowing into the muscularis propria, the thick muscle layer that helps the colon move stuff along, making the invasion deeper and more serious.
So what would T3N1 be? Why not T4N1?
All right, let's keep the storytelling vibe and dive into what T3N1 means in colorectal cancer and why it's not T4N1, keeping it simple and sticking to 2 sentences per response. Picture our rebel tumor in the colon, now at stage T3, having busted through the submucosa and muscularis propria and tunneling into the subserosa, that fatty outer layer of the bowel wall, or even the surrounding fat, but not yet invading nearby organs. The N1 part means the cancer's scouts have spread to 1-3 nearby lymph nodes, like sending spies to a few outposts, but it's not a distant takeover yet. M0. So, T3N1 is a locally advanced cancer, stage 3, specifically, where the tumor's deep in the bowel wall and has reached a few lymph nodes, needing surgery plus likely chemo.
Okay, let's play a game where I have to guess between T1, T2, T3, T4, yeah? And you just tell me what it was, and I tell you what it is.
Sounds like a fun game to test your colorectal cancer staging knowledge. I'll describe a tumor's invasion level from the TNM system, T1 to T4, and you guess which T stage it is, sticking to the colon or rectum. I'll keep it simple, 2 sentences per description, and we'll go one at a time. Here's the first one. The tumor has pushed through the mucosa and is sitting in the submucosa, that soft layer just below, but hasn't touched the muscle yet. What's the T stage?
One more time.
No problem. Let's rerun that first clue for our colorectal cancer staging game. The tumor has invaded past the colon's inner mucosa and is now in the submucosa, the connective tissue layer underneath, but it hasn't reached the muscular layer yet. What's the T stage?
T2.
Close, but not quite. T2 is when the tumor hits the muscularis propria, the muscle layer. The clue described invasion just into the submucosa, which is T1. Ready for the next one?
Yeah.
The tumor has grown through the submucosa and is now in the muscularis propria, the thick muscle layer of the colon wall.
T2.
What's the You got it. T2 is spot on for a tumor in the muscularis propria. Next clue. The tumor has blasted through the muscularis propria and is now in the subserosa, that fatty layer outside the colon wall, but hasn't hit nearby organs. What's the T stage?
T3.
Nailed it. T3 is exactly right for a tumor in the subserosa. Here's the next one. The tumor has broken through the colon wall entirely, invading nearby organs like the bladder or small intestine. What's the T stage?
I don't know, dude.
No worries. Let's wrap up this clue. The tumor invading nearby organs like the bladder or small
This is
intestine.
T4.
You got it. T4 is perfect for a tumor invading nearby organs like the bladder or small intestine. Want one more clue to keep the game going? Or
No.
shall we switch to another topic like bowel
Question.
cancer?
What is bowel cancer screening then? What does it consist of? Tell me about stool testing, to fecal immunochemical test.
All right, let's dive into bowel cancer screening, keeping it simple and clear, with 2 sentences per response, as you like, and weave in a bit of storytelling to make it engaging, focusing on stool testing and the fecal immunochemical test, FIT. Imagine your colon is a bustling city, and bowel cancer screening is like sending in inspectors to spot troublemakers, polyps, or early cancers before they cause chaos. Screening aims to catch colorectal cancer early or prevent it by finding precancerous growths, especially for folks over 50 or those with risk factors like Lynch syndrome or inflammatory bowel disease, using methods like colonoscopy, stool tests, or imaging. Stool testing is a key screening tool, and the fecal immunochemical test, or FIT, is a star player because it's non-invasive and easy. You collect a small stool sample at home. Think of it as mailing a tiny clue to the lab, and FIT detects hidden blood from tumors or polyps using antibodies specific to human hemoglobin, with no dietary restrictions needed, unlike older tests. FIT is done annually for average-risk people, and a positive result, meaning blood is found, triggers a colonoscopy to pinpoint the source, like a detective following a lead. It's highly sensitive for colorectal cancer, about 79% detection rate per a 2019 study in Annals of Internal Medicine, but less so for adenomas, so it's paired with other methods for high-risk groups. For context, other stool tests, like the guaiac-based fecal occult blood test, GFOBT, also check for blood but require avoiding certain foods and are less specific, while multi-target stool DNA tests, e.g. Cologuard, combine FIT with DNA markers for better adenoma detection but are pricier. In high-risk cases, like Lynch syndrome, FIT isn't enough. Annual colonoscopies start earlier, often at 2025, due to rapid cancer progression. Want me to zoom in on how FIT results are interpreted, compare it to colonoscopy, or maybe explore screening guidelines for specific groups?
Well, what's the science behind the stool test? What exactly is this? How do we test positive?
All right, let's dive into the science of stool tests for bowel cancer screening, focusing on the fecal immunochemical test, FIT, keeping it simple and storytelling style with 2 sentences per response. Picture your colon as a busy highway where tiny injuries from polyps or colorectal cancers leak traces of blood into the stool, like subtle clues left at a crime scene. FIT works by using antibodies that specifically latch onto human hemoglobin, the protein in red blood cells, detecting even small amounts of blood invisible to the naked eye. When you scoop a bit of stool into the Fit Kit's collection tube, think of it as sending a sample to a lab detective. The sample is mixed with a buffer, and the test checks for hemoglobin using an immunoassay, like a chemical handshake that lights up if blood is present. A positive FIT result happens when hemoglobin levels exceed a set threshold, typically around 20 to 50 micrograms per gram of stool, signaling possible bleeding from a polyp, cancer, or sometimes benign issues like hemorrhoids. This triggers a follow-up colonoscopy to pinpoint the source, as FIT doesn't diagnose cancer, but flags potential trouble with about 79% sensitivity for colorectal cancer, per a 2019 study in Annals of Internal Medicine. Unlike older guaiac-based tests, FIT doesn't react to non-human blood, like from red meat or require diet changes, making it more accurate and user-friendly. The science hinges on hemoglobin stability in stool long enough to be detected, though heavy bleeding or very early lesions might skew results, which is why FIT is repeated yearly for average risk folks. Want me to dig deeper into how labs set that hemoglobin cutoff, or what happens after a positive FIT result?
Sure.
All right, let's dive deeper into the fecal immunochemical test, FIT, for bowel cancer screening, focusing on how labs set the hemoglobin cutoff and what happens after a positive FIT result, keeping it simple, storytelling style, with 2 sentences per response. Imagine the lab as a high-tech detective agency, where FIT samples arrive like coded messages from your colon, and the hemoglobin cutoff is the clue threshold that decides if there's trouble worth investigating. Labs set this cutoff, typically 20 to 50 micrograms of hemoglobin per gram of stool, based on studies balancing sensitivity, catching cancers, and specificity, avoiding false alarms, with lower cutoffs detecting more abnormalities but increasing unnecessary colonoscopies, as seen in a 2017 study in gut. For
Okay.
example,
Thank you for watching, guys.